He is faculty in the Department of Medicine, Division of Neurology, and he's going to talk about Parkinson's disease. So let's give a warm welcome to Dr. Sherman.
It's easy for you to say. Parkinson's is fairly common, so if you deal at all with older people, you're going to see some patients with Parkinson's if you haven't already, which I suspect you have. The first description in the literature of Parkinson's was by James Parkinson, who was a British physician who wrote an essay about what he called the shaking palsy in 1817. And then a few years later, the famous French neurologist Charcot honored him by calling it Parkinson's disease. The French love to put their names on everything, so I guess I figured he couldn't put his name on Parkinson's disease. It's a degenerative disorder that involves the substantia nigra and Lewy body deposition in the brain. And one of the hallmark periods of the management of Parkinson's came in the late 60s when L-dopa had been tried, but the neurologist in New York named Katzius decided to push the doses of L-dopa up and actually discovered at that point that while lower doses didn't work, if you got enough dose of levodopa, it didn't. So it's a neurodegenerative disorder. There are over 1 million people in the United States affected with Parkinson's. About 350 per every 100,000 people over the age of 40. And people with Parkinson's have an increased mortality, not necessarily directly related to their Parkinson's, but because of all the complications that they get. Pneumonia and immobility and just the chronic neurologic disability. In terms of the diagnosis of Parkinson's, it's a clinical diagnosis that has 3 main features. It has a tremor, which is classically described as a resting tremor. So when the person is at repose with their arm resting, they get this, what's described as a pill rolling back and forth tremor. They get cogwheeling when you move their extremity and say place your thumb on their biceps tendon. You feel this ratchety type of sensation that is described as cogwheel rigidity. And then the other thing they get is bradykinesia and akinesia, so that they don't have as many spontaneous movements as they would normally. They don't blink as much as they do. They kind of seem to stare. They look very apathetic. When they rock, they don't swing their arms. It's generally thought of as a symmetric disease, and it involves both sides of the brain, so you'd expect it to be. But very early on, Parkinson's is not at all uncommon to be asymmetric. So a patient will come in and now have more tremor and more rigidity on one side than they do on the other. It's commonly both underdiagnosed and misdiagnosed. So you see patients who, because of their apathetic appearance, and sometimes they have a little memory trouble, they're thought to be depressed, say for example. One of the most common misdiagnoses that we see are people with essential tremor. And this is a different kind of tremor without akinesia and rigidity. And this is the Katharine Hepburn type tremor in the voice and the head, and they spill cups and food when they try to eat. And has an entirely different treatment and different prognosis, but it's one of the common things that's misdiagnosed. The other problem with misdiagnosis that I'll talk a little bit about is the differentiation between Parkinson's disease and Parkinsonism, which can be hard for us to sort out who deal with Parkinson's patients all the time. And I'll describe that a bit for you later. Parkinson's is not really considered as one of its major characteristics a loss of memory, but memory and dementia are very common in Parkinson's disease. About 40% of the patients have some memory difficulty, most commonly no associated illness other than the Parkinson's. But about 30% of the time, Alzheimer's disease coexists. And then there's a dementia called Lewy body dementia, where they get these Lewy bodies in their brain, and they can be demented on that basis. And then there are people who have cerebral vascular disease and get multiple little brain infarctions, and they can also develop Parkinson's features. Depression is common in Parkinson's disease, and it's always a little bit problematic because the Parkinson's itself makes people look depressed. They don't have the same spontaneous smiling and gesturing that they would normally. They look kind of apathetic. And so people may discount depression as just one of the features of bradykinesia and akinesia. So you have to be aware of that. The other cognitive change that I'll talk about in a bit in more detail are the hallucinations that these people get related to their medicine. And this can be a tremendous problem, trying to deal with the particularly nocturnal hallucinations that people on the levodopa get after a long period of time. So what's the difference between Parkinson's disease and Parkinsonism? Parkinsonism has many of the same features. Usually it doesn't have as much tremor, but it has the akinesia, the bradykinesia, and the rigidity that's similar to Parkinson's. And what are the disorders that lead to that? Well, in psychiatry, with the neuroleptic agents, many of these agents produce side effects that look like Parkinson's. So they have extrapyramidal side effects related to their thorazine or whatever. People with vascular Parkinsonism are people with vascular risk factors. They have hypertension, diabetes, atherosclerotic disease, and they have multiple little infarcts. And because they involve the basal ganglia and the deep white matter, these people also develop akinesia and bradykinesia. And then there's a whole list of inherited and other degenerative disorders that aren't that common, but have as a prominent feature extrapyramidal disorder. They usually have other features that differentiate them from Parkinson's disease. The neuropathology of Parkinson's, the dominant one is if you look at a normal brain that's been stained and sectioned, if you look down at in the cerebral peduncles, the corpus callosum looks, the substantia nigra looks dark, black, and that's the nigral, striatal nigra part of the brain. And that's where dopamine is produced, and that's the major finding that's consistent with Parkinson's disease. So these neurons progressively die off. As they are lost, the level of dopamine production goes down, and that's what leads to the symptoms of Parkinson's. They also lose some cholinergic neurons, and they lose other neurons that explain some of the other symptoms of Parkinson's. Parkinson's patients also have sometimes difficulty with smell. They oftentimes have a lot of autonomic features, postural hypotension, alternating diarrhea, constipation, bladder difficulty, and that sort of thing. What causes Parkinson's disease? The bottom line is we don't know. There are hints that it may be due probably not to a single disorder, but to a confluence of a number of influences. And these include genetic factors, neurotoxins, excitotoxins, absence of neurotrophic factors, and possibly some immune factors. What's the evidence about the genetics? Well, if you look at identical twins, if you have an identical twin who has Parkinson's, your risk for Parkinson's goes up dramatically. And also in the patients with Alzheimer's disease and Parkinson's disease at young onset, there's been a gene identified on chromosome number 4 that seems to be responsible. So the hypothesis is that it's not a strictly genetic disorder like muscular dystrophy, Duchenne's dystrophy, or something like that. But there's something about your genetics that probably makes you more or less likely to develop Parkinson's disease if you get exposed or have the right other stresses on your brain. Toxins. MPTP is a substance that was an unfortunate byproduct of homemade Demerol. And this byproduct produces Parkinson's. And there were a group of patients who used illicit Demerol contaminated with this toxin who developed severe Parkinson's disease. And now, and so it was isolated and discovered that this was the toxin that was responsible. It destroys the substantia nigra. So now this is really the substance that's used to create animal models for Parkinson's. So if you have if you want to study some of the features of Parkinson's or the treatments for Parkinson's, you create a group of, say, primates with MPTP who have Parkinson's. They're bradykinetic and rigid and have tremor. So that's one of the clues that Parkinson's may be related to toxins, since we know that this toxin can produce Parkinson's disease. Back in the 1918s or so, there was an epidemic of flu in this country, and people who developed that flu in the epidemic, subsequently many of them developed Parkinson's. Most of these people are dead now. But in my early career, we used to see these patients occasionally, and we're still alive after developing Parkinson's disease, years after developing the flu. So suggests that there may be some toxic effects of certain viruses on the substantia nigra that can then be delayed in the loss of neurons in the substantia nigra and lead to Parkinson's disease. There's some evidence that excessive oxidative stress and may be contributory to Parkinson's disease, and also there seems to be increased iron deposits in the substantia nigra. So question about whether that metal might be somehow or another related as a toxin to the development of Parkinson's. The other theory relates to neurotrophic. Our brains have a number of neurotrophic factors that encourage the maintenance and development of neurons in the brain. And these include glial-derived neurotrophic factor and brain-derived neurotrophic factor. And if you take those animal models that I mentioned of Parkinson's and you give them these trophic factors, it can be protective and it can help them not develop. So that's led to the idea that perhaps one of the causes for Parkinson's may be a reduction or a lack in these trophic factors that help sustain and maintain these dopamine neurons in the brain. So if you lose the nurturing and the supportive and the trophic influences of these factors, then these neurons tend to die off more quickly. And then based on pathology and some of the serologic evidence of immune reaction, there's some suggestion of a possible immune disorder. It's always hard there to know, because if you have neurons that are dying, you may get an inflammatory or immune response. So it's kind of hard to tell oftentimes which comes first. Does the sick neuron occur and then the brain tries to clean it up, or is there some inflammatory process that then leads to the loss of the neurons? Treatment of Parkinson's. We have basically three strategies. The first strategy is the one that we use most, and that's symptomatic treatment. The problem with Parkinson's is the brain has lost these cells that produce dopamine. And so we give dopamine, and that's what cinnamon is. That's what levodopa is. So we do various things that will increase the brain supply of dopamine. Then we have protective strategies. In other words, are there things that we can do to keep the substantia nigra from deteriorating, keep these cells from being lost, maybe give them early in the early phases of Parkinson's to keep them from getting worse. And then one of the treatments that's very much in the news in the future, hopefully, is to increase cell growth either by neurotrophic factors or by the use of stem cells or other strategies to try to replace these neurons or stimulate the neurons that are there to restore their dopamine production. The mainstay for treatment is levodopa, which now we use clinically as a combination of carbidopa-levodopa, which is known as Stimulation. And it's really the most effective treatment for Parkinson's disease. And I consider it a diagnostic test in a way. Because if you see this patient who maybe has been on neuroleptics or maybe has some vascular disease, and you're trying to differentiate true Parkinson's disease from Parkinsonism, if you give that person some sentiment, if they have Parkinson's disease, they'll typically come back and say, oh man, I can move better, my tremor's better, I feel much better. So it's sort of a confirmatory experimental treatment that substantiates our diagnosis. So initially we used to use just levodopa by itself, and it required very high doses of levodopa. And then carbidopa, which is a peripheral decarboxylase inhibitor, came along to prevent the systemic degradation of levodopa. So we were able to combine the two and use much lower doses of levodopa. So now it's available in both immediate release forms and a sustained release form. Many patients, we use a combination of the two. Say, for example, I'll have a patient take an immediate release when they first get up in the morning to kind of get them going, and then if they can be adequately controlled with a sustained release preparation, and give that through the day because it's a little bit smoother in terms of its release of dopamine. And then there are some COMT inhibitors that can prolong the benefit of levodopa by reducing the degradation of levodopa in the body. So levodopa works great, but it has problems. And the problems occur after the person's been on it for a while. For a while, I mean usually several years. And it's odd because some people seem to get the problem more than others do. It tends to be dose and time related. So that the higher the doses you use and the longer you use it, the more likely you are to get these complications. So the complications include the motor complications, which are the dyskinesias. The patient gets at the peak dose usually. So they're rigid, they take their Stimulation, and then an hour later, 30 minutes later, they're much better. They stay well for an hour or so. And then at the peak time of their blood level, they start to get these dyskinetic movements. Now, most people with Parkinson's, this doesn't bother them. I mean, they'd rather be dyskinetic than to be rigid. So they can kind of continue to function with all these movements. It usually bothers the people around them and their physicians more than it does the patient. But it's very, in some patients it can be a very big problem. Mental status changes, again, as time goes by. Confusion, visual hallucinations, psychosis, and then some motor changes that I'll get into in a moment. So the motor complications are kind of two categories. On the right are kind of the ones that I mentioned, the dyskinesia. And the dyskinesias may be related to the blood level, in which those are called peak dose dyskinesias. So that's predictable. You take it, and then at the point in time when your dose would be max, your blood level would be maximum, you get the dyskinesias. You can sometimes overcome that by trying to keep the dose and the level in the blood from getting too high. So you give a sustained release variety, or you give smaller doses at more frequent intervals, rather than give a large dose where you're going to get a peak in the blood levels. Then the other problem is these people get motor fluctuations, called on-offs. And so that these people are suddenly go from well-controlled to within a few minutes to rigid again. It's like something happened and the medication is no longer effective. So they have these sudden off periods of time, and they can also be related to the blood levels and the time that the dose was given, or they seemingly can just be random. And people also have freeze-ups and other kinds of motor abnormalities. Some of these symptoms of treatment and Parkinson's are not responsive very well to levodopa. Postural instability, for example. The features of Parkinson's, the tremor, the rigidity, the bradykinesia, vary to different degrees in different people. One of the other main features is postural instability. So sometimes you have a patient with Parkinson's who has their major manifestation is tremor. In other people, their major manifestation is bradykinesia. Some of the most difficult and frustrating patients are those who have postural instability. They have falling spells. And with Parkinson's, they typically have propulsion or retropulsion. And what they tell you is, well, I kind of am walking along and then I kind of get to going forward and I can't stop and I fall. Or I get tipped back just a little bit, I go backward and I fall. And that tends not to be responsive to cinnamon. People can have freezing episodes where just all of a sudden they're just frozen. One of the most humorous treatments I heard for this was one that was related by not my patient but another patient who would have freezing spells, and for some reason, I don't know if he was frozen one day and on the radio comes a Sousa march. So he used to carry a little recorder, and whenever he would freeze up, he'd push this, and this John Philip Sousa march would come on, and he could walk again. It's an odd. The speech abnormalities, and for some patients with Parkinson's, I've had patients that's their major complaint. They can't talk on the phone because they have hypophonia. They have this low whispering voice, and they can't make themselves understood on the phone. Now there's some speech therapy programs that are specifically designed for these people that are very effective. Basically, they teach these people to pretend they're yelling. And but even so, many times these hypophonic speech disorders are not easily managed, and they don't respond to sentiment. The dementia, the depression don't respond to sentiment. A lot of patients with Parkinson's, you remember the autonomic nervous system is also involved. So they get a lot of autonomic features. And they get constipation, diarrhea, urinary problems, sexual dysfunction, sweating problems, etc. So that's sentiment. We actually give a precursor of dopamine and levodopa. The other strategy is not to give the dopamine, but give something that fools the brain into thinking it's dopamine. The dopamine agonist. And here's a list of them. Bromocriptine's the oldest one around, and there are several others. And now one of the things that's used is injections of apomorphine, which work very well. And they have apomorphine pumps for certain patients who are very resistant to management of their Parkinson's. So if you compare cinnamon or levodopa to the dopamine agonist, how do they compare? Generally, they're less effective than levodopa. I mentioned that levodopa is really a diagnostic test for Parkinson's, especially early on. You give somebody cinnamon, if they have Parkinson's, they have a very rapid and dramatic response. That's not as much the case with the dopamine agonist, but they do have a little bit less risk in the long run of developing these dyskinesias and these motor fluctuations on-off compared to the patients who we give cinnamon to. You have to titrate them up very slowly over the course of time. And as a general rule now, the recommendations are that in terms of picking the first agent for management of Parkinson's, the younger the patient, the more likely you are to pick one of the dopamine agonists. Okay? Because usually they got mild Parkinson's. You want to sort of delay sentiment as long as you can to avoid the inevitable dyskinesias and hallucinations and other problems. So you start with the dopamine agonist, and then as time goes on and the Parkinson's becomes inadequately responsive, then you add sentiment to that. Some of the other drugs we use, some of the oldest drugs that were available were drugs that block acetylcholine, artane, and cogentin. These are used, as you know, in the psychiatry patients who have extrapyramidal symptoms related to their neuroleptics to try to block those effects. But these agents can cause particularly older people to have periods of confusion, and so you have to be very cautious about using them in some people. Amantadine use for Parkinson's was discovered, again, by accident, as many things in medicine are. It's an antiviral, anti-flu agent. It was given to a bunch of patients to try to keep them from getting the flu, including 3 patients with Parkinson's, whose Parkinson's got much better. And so now we use amantadine very commonly. It enhances release of dopamine, serves as an NMDA antagonist, and it reduces dyskinesias. So it's a nice additive treatment to, say, sentiment, and you put people on amantadine, and it's easy to use twice a day. Very few side effects. Selegiline is a MAO and B inhibitor, so it increases the amount of dopamine in the circulation. The hallucinations. Some people don't get hallucinations, but some people get. After a long period of time, on higher doses, they get hallucinations. One of my patients, he was a very smart guy. I treated him for Parkinson's for 15 or 20 years. And he never wanted to push his medicine up because he kind of knew about this. But he eventually developed hallucinations. And his hallucinations became very stereotyped. And the hallucination was, every night, 3 guys in camouflage would break into his house and go around and steal things and then leave. And he would wake his wife up. She was beside herself because she couldn't sleep through the night. He'd wake up yelling at these guys, "Where's the guy? Call the police." All this kind of stuff. And he was a smart guy. You could talk to him about this, and you could say, well, was the window broken? Was the latch jimmy? Was there anything taken? Et cetera, et cetera. And at first, he kind of recognized that they weren't real. But later on, he would maintain that one of these days, I'm going to prove to you, his wife, that these guys really come in every night. It defied logic. But it was a very stereotyped hallucination that he had. And these can be difficult to control. The first thing we do is try to reduce their dose of particularly the sentiment and see if that will get rid of them or change their schedule around, because the hallucinations tend to be worse at night in the dark. And then the 2 agents that we use are clozapine, which works very well, but you have to monitor the CBCs on that drug, very regularly, so it's a bit of a hassle to use. And then Seroquel is the other agent that's used, and probably now it's kind of become the first-line drug to try because it's so much easier to use than clozapine. What about things that are in the pipeline for treatment of Parkinson's disease? Well, the problem with the absorption and the smooth release of levodopa is a bit of a problem, and so other forms are being developed. MAO inhibitors to try to sort of maintain the level at a smoother level. inhibitors of dopamine uptake so that the dopamine isn't destroyed quite so quickly and you maintain a level in the blood and in the brain more particularly. Nerve growth factors. Is there some way that we can give nerve growth factors to try to stimulate these few remaining neurons that are there, these dormant dopamine-producing neurons, to then regrow and start to produce dopamine again, and some other agents. The surgery of Parkinson's is an interesting history. It again seems like everything in Parkinson's was discovered accidentally. There was a surgical procedure being performed, I think it was in New York, and the surgery was done. The patient had Parkinson's. The surgery wasn't for Parkinson's. In the recovery phase, it was noticed that his Parkinson's on one side was much better. And scans, etc., showed that he had a lesion in the thalamus. This was an interesting lesson, I guess, in academia, because the resident or fellow who was attending at the surgery kept his mouth shut about this. He made this observation until he got to be the attending. And then he went back with this idea and said, maybe we could make lesions in this area and treat Parkinson's. And so he became one of the most famous people for the surgical treatment of Parkinson's based on that kind of observation and connection that he made. Thalamotomy is one of the first procedures that was undertaken, usually done stereotactically. You put a stereotactic probe in there and you destroy part of the thalamus. But there are complications related to that. Because you're messing around in the thalamus, the person can get sensory problems on the opposite side. They can get dystonic movements or slurred speech and some cognitive changes. So it's not without some problems. It's one of the oldest procedures done. The other, so there are kind of two, I think of it as two broad strategies. One is you put a lesion there and destroy part of the brain, try to help. And the other strategy is you put a stimulator in there, a pacemaker in there, and then you stimulate that part of the brain to interrupt its pathways and help in that way. So deep brain stimulation is kind of evolved as the more fashionable way to surgically manage patients with Parkinson's. Now, thalamic deep brain stimulation was one of the first ones that was tried. Had fewer complications. As you can imagine, you put an electrode in there and you destroy a little brain, a few million cells, but you don't destroy a billion cells. And you can titrate. I mean, you have the pacemaker here, and you can turn it on, turn it off, adjust it, adjust the frequency, and that sort of thing. So it's not, I mean, once you make the lesion there permanently, it's there. But if you have the deep brain stimulator in, you can tune it in a little bit. But the problem with the thalamic deep brain stimulation is, while it helped the tremor, the real kind of disability and dysfunction that patients had didn't really change very much. Lesions in the globus pallidus became a more common site for a destructive lesion. And the idea here is the circuitry that's messed up in the basal ganglia from the substantia nigra to the basal ganglia. You interrupt that circuitry by putting a lesion in the globus pallidus, and it improves. But there's controversy in the Parkinson surgery world about exactly where in the globus pallidus is the best place to put the lesion. And it's not the favored treatment anymore. It does help the contralateral dyskinesia, so if you have a patient who's really disabled by these drug-induced dyskinesias, it's very effective there. And it also does seem to improve some of their disability scales. The deep brain stimulators are more common, as I mentioned. The globus pallidus deep brain stimulator. It improves all of the features of Parkinson's. It's probably a little safer than those lesions, than the deep brain stimulators in the globus pallidus. It's possible to put pacemakers or stimulators into both sides of the brain, but there's a little bit of a risk of worsening any kind of cognitive problems or adding cognitive problems to the mix of these patients. Now, the subthalamic nucleus is another site that's overactive in Parkinson's with producing excessive excitatory glutamate, and that stimulates the basal ganglia and makes the symptoms of Parkinson's worse. So the idea is you put a lesion there and you interrupt that part of this complicated circuit and improves Parkinson's. The problem is the subthalamic nucleus is right close to a part of the brain that if you destroy it, we see it in people who've had a stroke, they get hemiballismus. I don't know if you've ever seen anybody with that. These are these violent flinging movements in the extremities on one side that people get from lesions very near the subthalamic nucleus. Deep brain stimulators in the same place. About 60% of the time their symptoms of Parkinson findings are decreased. Sometimes there's rather striking improvement in the tremor. And you see, we've had some patients who've been shown to have ran rounds with stimulators in place, and they have their magnet, they turn the stimulator off, and they have this terrible tremor. They stimulate it, turn the magnet on, turn the pacemaker on, and the tremor goes away. It's terribly impressive. But again, we should only show the good cases. There's a surgical trial underway now within the VA system. It's a very well-designed randomized trial, and it's to compare pallidotomy with bilateral subthalamic nucleus deep brain stimulation. Probably the trend is, and the perception is, the deep brain stimulation and the subthalamic nucleus is the favored management, but this has never been really well studied. And so this is a way to look at that, and they're looking at the disability and the features of Parkinson's at a 2-year time frame. And then in terms of restoration of the basic underlying problem, there's the issue of transplantation in patients with Parkinson's, so that if these dopamine neurons are missing, have died off, then can we take fetal cells, stem cells, whatever, other kinds of cells, and implant them there, and they begin to produce dopamine and replace the brain's dopamine in that way. This is one of the similar strategies relates to, I mentioned the growth factors, or the neurotrophic growth factors that maintain and stimulate nerve growth. So you can put these into a viral vector and inject them into various parts of the brain. And in the experimental animals, they will then stimulate the dopamine neurons to become more active and healthy and produce more dopamine. And you can do that either by injecting them in the substantia nigra or injecting directly into the putamen caudate. Other treatments, shock therapy. Seems kind of weird. Actually, one of our local psychiatrists is very interested in this and has treated a number of our patients. So that patients who have severe Parkinson's, not responsive anymore to medications, whatever, ECT is used in those patients. The other treatment that's now being looked at is transcranial magnetic stimulation. You put a huge magnet over the head and you periodically do these stimulations. I'm not sure what the pathophysiology is. Presumably it sort of stimulates the parts of the brain to be more either productive of dopamine or more receptive to its effects. So to summarize, Parkinson's disease falls into that broad category of one of the neurodegenerative disorders. Its cause is probably multifactorial. It doesn't have a single cause. You probably have to have maybe some genetic predisposition, and then maybe you get exposed to certain toxins, like rural agricultural workers seem to be more likely than urban people to develop Parkinson's, and so the idea that some of the pesticides or herbicides may have an influence. There may be immune factors that are important, but it's probably several of these factors that come together. The treatments that we use every day are really symptomatic. So they don't cure the disease. They treat the symptoms. And unfortunately, as the treatment goes on, after years and years, these drugs start to not become as effective, number one, and number two, they have associated side effects. But the number of drugs that we have available has been expanding quite a bit in the last several years. So that now we have more and more drugs that make it easier to treat these patients and make it easier for the patients so that they get a more even response in their Parkinson's symptoms. The use of surgical procedures is becoming increasingly common, and particularly patients who have Parkinson's or have developed dyskinesias or have predominantly tremor as a manifestation of their Parkinson's. One of the surgical procedures works very well for them, and there are a couple of people in town who do a lot of these. One person here at the university and another person in the community. Now I would say the trend, as I mentioned, is going away from putting a destructive lesion in the brain and towards putting a stimulator in there, because it can be controlled. You can adjust the stimulator, you can turn it up, turn it down, change the frequency, turn it on, turn it off, and you don't have to destroy the brain as much when you put the deep brain stimulator. And then the future may be really in identifying at an earlier stage the people who are going to develop Parkinson's, and also the idea of applying preventive strategies to try to prevent these people from advancing their Parkinson's. And then finally, the use of some of the replacement therapies in terms of stem cells and viral vectors and trophic factors, etc. So I think that's it. Yes?
Are there early signs that these patients can recognize and kind of like stop that from progressing?
Well, I would say, it depends on which features predominate in a given patient. People have tremor, they notice that, everybody notices that. The problem with tremor is a lot of patients that we see who have essential tremor are called Parkinson's. It usually goes that way. It's rare that we see somebody with Parkinson's who gets called an essential tremor. People who have rigidity, they don't really complain that much. The other group of patients who will notice it and complain a lot are obviously those who have postural instability, the ones who tend to fall. And they'll come in with these falling spells, and they just lose their balance with propulse or retropulse. Does that answer your question?
Well, I was just wondering if there's anything that they can, before they get to that stage of tremor. What about losing the sense of smell? Have you heard of that?
Yes, yeah, that's part of their, they lose olfactory neurons, so it goes along with the neurodegenerative nature. And some people have a lot of autonomic features. And there is a syndrome called, another neurodegenerative disorder called shy Draper. And these people have terrible autonomic dysfunction. These are people who have to wear spacesuits in order to stand up because they have no blood pressure. And they have a lot of Parkinson's features. The usual Parkinson's patient has a lot of Parkinson's features and a little bit of this autonomic.
One more question. Yeah. We, in a dental office, as a hygienist, I have quite a few of those patients. Is there any time of the day that is better to treat these people? Or like, say, because you're saying as far as the medication.
Right. Well, I think you have to individualize it. What I would do is I would ask the patient in terms of their schedule of medication, and if they have if it typically would be in the morning, so if they get up, they take their medicine, and then an hour or 2 hours after they take their medicine, they're going to be best, probably easiest to work with. And
Yeah, that's.
oral dyskinesias can be a tough on a dentist, I imagine. A little bit of interference. The other? Yes.
Does Michael J. Fox and Muhammad Ali, do they have Parkinson's disease?
Michael J. Fox definitely has Parkinson's disease. Muhammad Ali, I think, also has Parkinson's disease, but the question about him is, does he have Parkinsonism because of his boxing career? And a lot of, I have a patient downtown in the clinic who has Parkinson's, and he fought 65 fights. He was a low-level club boxer, knocked out a lot of times. These people have some changes in their brain. They have calum septum pellucidum for some reason. But my guess is certainly Michael J. Fox does. Whether Muhammad Ali has a combination of some Parkinson's, but I think probably a lot of Parkinsonism. It falls in that category of repeated head trauma, or any kind of brain insult can be manifest with a lot of Parkinson's features. Muhammad Ali doesn't have much in the way of tremor that I've seen. He just has striking bradykinesia. He's very, he doesn't float like a butterfly and sting like a bee. Is that how it went? Yeah. Crawls like a snake. Yes?
That VA surgical quality stuck out, is that this VA?
No, unfortunately. Actually, I was the PI on the proposal here, and we were very competitive, and we actually went to the central office in Washington. We were one of the, I think, the 6 groups that in the finals, in the semifinals, and at the very end, they decided that they were only going to fund 3 instead of 6. The main impediment that we had at the time was that, and we had an excellent sort of research and basic science proposal, was that we were using, that was when neurosurgery was kind of falling apart here. And so we were using one of the neurosurgeons in town who actually had a lot of experience, and if he just had probably the credentials of being at the university and the VA, he would have been okay. I think now, if we were to do the same thing again, and we have neurosurgeons here who are experienced and knowledgeable about Parkinson's, we would have a better chance. Unfortunately, no. We try. Yes?
You talked about, the biopsy with DBS. Can you not do that with the palmar or paladotomy? You don't do it bilaterally?
You can do it bilaterally. With the paladotomy, you have to do it kind of staged. With the deep brain stimulators, you could put them both in at the same time. With the paladotomy, because of the complications, you want to do one and be sure you don't get major problems, and then a year later, do the other one. So. Okay, thanks for inviting me.